Hello, and thank you for joining us in The Loop, the podcast where we provide a platform and questions for those who are running or attempting to run our health and care system. I'm Neil Dickson, one-time BBC News broadcaster, and thereafter Chief Executive of the King's Fund, the General Medical Council, and the NHS Confederation. I am, as usual, joined by Roy Lilley, former NHS Chair, and relentless and persistent commentator on health matters. Welcome, Roy.
Hello, Neil.
Our guest today is Rob Webster CBE. Rob is the Chief Executive of NHS West Yorkshire Integrated Care Board, or ICB. It's one of 42 boards responsible for overseeing the NHS across England. Among his many management roles, Rob has been Chief Executive of NHS Calderdale Primary Care Trust, Leeds Community Healthcare NHS Trust, and South West Yorkshire Partnership NHS Foundation Trust. And like me, he was Chief Executive of the NHS Confederation, in his case between 2014 and 2016. Rob has received much praise for his commitment to issues such as collaboration, diversity, and tackling health inequalities. But like senior managers across the NHS, he's presiding over a system under immense strain, subject to major scandals and struggling to meet demand and provide the care that patients need. As a reminder, ICBs were set up to, I'll give you these four things: bring together health, social care, primary care, and other local partners to plan and deliver care more coherently, shift the focus from acute care to population health prevention and community and home-based care, improve integration across services, reduce fragmentation, align resources better, reduce waste, improve outcomes, and reduce inequalities. And last, exercise strategic commissioning, allocating NHS budgets, overseeing local provider performance, and driving local improvement. Not a tall order. So today, Roy, I hope we can separate the wheat from the chaff with our frontline leader who's been responsible for all of this. First, his view of the latest reorganisation, which will see mergers, fewer ICBs, fewer staff, more cuts. How bad is life in ICB land, and how are his staff and their morale? And secondly, I'd really like to know, what's the reality of their financial position, and what, if anything, have they really achieved? And last, how different will all this be in future? We're heading for a world of so-called integrated care organisations, bringing community and acute provision together. Is that the future? Now, some would say integrated care boards have done little but presided over a system in meltdown. Others would say they were near strangled at birth and never had a chance to show their potential. Roy, your take.
Well, look, ICBs were born during the sort of fag end of COVID. It was a terrible time to introduce a new organisation. They also inherited the debts of their predecessor organisation. The word at the time was that their debts would be wiped out and they'd be given a clean balance sheet, but they weren't. So they were born into poverty, into penury at a dreadful time in the history of the NHS. Now, of course, they've got to lose half their staff, I think, by Christmas, and no money to make anybody redundant. You have to have done something really bad in a previous life to end up running one of these ICBs. So God knows what he's going to say. I have no idea. But you are right. This takes us to the heart of the struggle for the future of the NHS.
It's not a new problem, is it? We seem to have been moving these deck chairs around. Just reflecting the organisations that he's been chief executive of, but also endlessly the titles of these organisations change. We switch them around. We want so many regions, and we want fewer regions. We don't want regions. We want area health authorities, district health authorities. And every time we do it, not least in the last disastrous reorganisation, there are expectations put that somehow we've solved the problem. And far from solving it, we seem to make it worse every time.
We do. I was talking to a group of managers the other day, and I said to them, you know what, I used to run an ICB. And they said, what? When? And I said, well, it was called a district health authority, and it was back in the late 70s and 80s. But there is a parallel between ICBs and district health authorities. Fast forward to today, I think ICBs could be the district health authorities. And of course, they've got much better computing power, IT. They know how much they're spending on a daily basis, really. They should be able to make a difference. But the trouble is they're dragging so much baggage that I can't see how they're going to do it. And look, let's face it, Neil, there's 40 odd of them. It's far too many. We're going to have 7 or 8 regions, probably 10 in the long run. I think their work is going to be subsumed into the regions, and the big hospitals will run the local health economy with a vertical integration with primary care. That's the sort of cardinal sin to ever pronounce a future for primary care that hasn't been signed and sealed by the BMA. But that's where I think this is going. And the quicker we get there, the better. But it's going to be a painful process.
And I read out those things that ICBs were meant to do. They're now narrowing it down into just strategic commissioning and presumably ditching all the rest of the stuff. But the rest of the stuff was massive. And yet, right from the get-go, they were told to cut their staff and cut their operating costs.
Yes, they can't do the job. I mean, if you have a look at West Yorkshire, where our guest is in charge, the life expectancy between the most and least deprived areas in West Yorkshire, for men, the gap is 10 years, and for women, it's almost 12 years. That's horrendous. I mean, it really is horrendous. And what can he do about it? What power does he have? What levers can he pull? What money has he got to invest in? How are they going to do it? The answer is, I don't think they can. But we'll find out, Neil. We'll find out.
Let's go and welcome Rob Webster. Rob, thank you for joining us in the loop. You're not quite in the front line or as much in the front line as a charge nurse in A&E, but you're a lot closer than the Secretary of State or some of the policy wonks at the centre that we've been talking to. So I guess the first question is, how difficult is it out there for your staff, including in all the providers, and how tough is it for those needing healthcare or social care on your patch?
It's interesting, isn't it, when we ask leaders questions about how difficult things are, they're always difficult. And I recall, when I was Chief Executive of the NHS Confed, asking all the chief execs at the Confed conference, several hundred of them, who's been here the longest? And people have been in post or in the service 20, 30, 40 years, and every year was a challenging year. And those things persist. I think what we've got to do as leaders in the system is think about, what do we do about it then? Anyone can tell you how difficult things are. So right now, clearly we are dealing with a significant number of issues. We've got a population here in West Yorkshire which is more deprived than most of the rest of the country. We have a workforce which has been through a lot and continues to amaze me with its can-do spirit. But we've also got parts of the workforce which are taking industrial action, which is a significant pressure on all of us. We have some financial distress for ourselves and our partners, and we have a substantial amount of organisational change going on. So if you put that together as a cocktail, you could easily get into a spiral of despair and think that everything is unfixable. But I don't think I'm in that space, and I don't think we are either as people in our system.
In one sense, things have got more difficult. You've come out of COVID and you've got arguably more money. You've got certainly a lot more doctors in the hospital sector, and yet things financially are worse.
We actually broke even with the in 24-25, and in 25-26 our plan is for a 49 million deficit with 49 million of deficit support funding for 2 of our providers. And we're able to get to that sort of position on the basis of the joint work we do together as organisations. And I would say the big strength of West Yorkshire is that all of the partners are in the partnership. So the trusts, the GPs, the councils, the third sector and ourselves. And we look at the financial risks in the round and we're honest about what the risks are. So there isn't this sense of people gaming the system to try and get the best outcome for them. What we all do is say, okay, where does the most risk sit and how do we balance that across the system to get to a position where we can deliver the bottom line with some substantial efficiencies. But that financial grip, rigour, focus on risk is critical. What's more critical is that we keep a focus on what's the money for, and the money is to invest in improving outcomes for local people. And we can only do that if we do that together. So that financial distress, yes, it's real. Yes, it will continue. What we have to do collectively is say, well, what do we do with that money? How do we get the most out of it? And how do we do that in a way in the medium term is going to improve things for local people who face significant inequity?
Can I just ask you, Rob, I mean, on top of all that, you've got to do 2% productivity and they're taking away the deficit support, all you can do is let people go. That's your biggest cost. So how are you managing the redundancies? Because Streetings turns up and says, effectively, you've got to let half your staff go. And then you say, OK, but where's the money for the redundancies? And nobody's bothered to talk to the Treasury. So there isn't any money for that. And that was clear from the interview we did with Jim. So what are you saying to staff who say, well, boss, am I going to have a job by Christmas?
Well, it's incredibly difficult. It's one of the most frustrating periods in my career. And I've been through some interesting times. I mean, I'm around for 36 years now. One of my organisations was abolished live on Newsnight by Andrew Lansley, and I had to go and face the staff the next day. So it's something that we've been through before. When the announcement was made, live from the meeting we're having in London, I did a broadcast for all staff to say, look, this is happening and this is what we're going to do about it. And since then, firstly weekly, then fortnightly, I've been having 90-minute conversation with staff about where are we now. And we did a lot of work. By the end of May, we had a structure and an approach which would take us to it's 45% reduction for us with a very different structure. And what we've subsequently had is the situation that Jim's described to you, which has been unclear about how that would be paid for. So we've got a financial target to deliver this year of a 49 million deficit with 49 million deficit support funding. Adding the additional cost of redundancy blows that out of the water. We can't go further than where we are. Therefore, we either have to change the forecast or we have to find some resource. Now, what I've been saying to staff, that's the position that we're in. And to be fair to them, what I've been humbled by, as ever, is that they've just continued to get on with the job. The work is essential in a context where we've got multimorbidity, deprivation, and inequity of access driving poor outcomes for people and, a set of services which aren't designed to deliver what they need. So we have to work together in the system to make that change. We can do that, I think, and we can do that in the medium term, and we have to continue it through transition. So for the staff, we keep focusing on the work matters. Our partners at NHS England aren't ready to pick up some of the functions that we've got yet. So let's keep going until we can manage it through. If that changes, we will get on with the redundancy programme. And I think people are generally focused on why they come to work, but there is harm to staff during this period.
It looks to me like this is going to be like pulling the legs off a spider. It looks like a 3-year package of letting people go if you can find the funding internally to do either voluntary redundancy. Jim is saying there were 3,500 people who stepped forward for voluntary redundancy, which is fine. And if it suits them, good luck, but it's nowhere near enough. I mean, we're talking triple that number. Streetings turned up with no plan, no idea, no impact analysis and no money and chucked everything up in the air. So how do you approach that?
So what do we want? Everyone would get behind a smaller centre, regions that are looking at performance of providers in the system, strategic commissioning from ICBs, providers who collaborate to deliver joined up care to people in the population, particularly those with multimorbidity in children, and a single quality regulator. We all want that. I think that's better. We've all been complaining about it's too complicated, centres too big, regions and ICBs, there's a bit of duplication in different parts of the country. Let's simplify it all. So we want to get there. Everyone can sign up to that. The transition is incredibly difficult. And the way that I approach it is to keep focused on the why. Why are we here? What's our purpose? And our purpose is to improve outcomes for local people. Our purpose is to coordinate and manage the system across winter. We continue to do that. Our purpose is to make sure during the junior doctors' strike, there's a coordinated effort that makes sure that we do as much as possible on cancer and elective recovery and everything else, which we continue to do. When things change, we'll have to work with all bits of the system to make sure that those changes are coordinated in a way which causes the least disruption, and be honest with everybody that there'll be disruption.
To be an effective organisation, the NHS presumably has to have people who feel good coming to work in the morning. Yeah. You've described some of the pressures on your own staff who will not know whether they have a future, and they don't know what kind of organisation, likely to be some kind of merger and fewer ICBs than there are now. But what about staff more generally? And you mentioned the industrial action, and It is true that if you ask the BMA, they will tell you that doctor morale is the lowest it's ever been. And they've been saying the same thing every year for as long as I've been involved in the health service, which is many years. But having said all that, there does seem to be at the moment levels of frustration and concern, particularly among doctors, but also among other professionals who are actually delivering the frontline care. Do you recognise that? And we haven't recovered even from COVID, have we?
I'll come back to the big picture. The NHS is made of people. Look at the conversation we're having. We've been talking really about structure. And what we've got is a people business where the majority of the money we spend is on people. Our role really is to make sure that if somebody needs help and somebody can give it to them, you bring those people together. Everything else in the system, every single thing in the system should be about making that the most optimal interaction possible with the two most appropriate people involved. And we spend too much time talking about structure and about the sort of transactional elements of what we do and not enough about the people we employ, the impact of the changes that we have on them, and how that then plays into their work with the public. And we should really orientate everything we do around our people. And that's always been my approach as a trust chief executive, of being a foundation trust chief exec, a trust chief exec, a PCT chief exec of the Confed. So it always starts with the people, because if we don't get that right, we're in trouble. Now, I think we've seen over the last decade or so, I think, a change in the social contract with our staff and a generational change in the attitudes of staff. And we've had the COVID pandemic. And I remember there were promises that staff would get some kind of break after COVID, and it never happened. For various reasons, it just never happened. So we've been through a period where, in my career, staff in a team would never leave the team and come back as an agency worker because they wouldn't feel it was right for their team, to one where we had a massive expansion in the agency staff and people feeling they were getting better work-life balance, breaking that social contract. We've been through a position where staff have died, changed the way that they work during COVID to make sure that we deliver the most care that we possibly can. And then a period where, quite rightly, people have become a bit dissatisfied with the way things are in the service for them. We need to do something about that. That's our job as a leader, is to support our people, create a vision for the future they can all get behind, put an arm around them all and say, we're here as organisations to support you. It doesn't feel like that everywhere all of the time, and we need to make sure that it does. And that's a leadership challenge at all levels.
How do you go about doing that, given the financial position? And I'm not saying it's all about money, but the financial position that you're facing is nothing like the years when waiting lists were turned around in the noughties and there was significant amounts of capital investment going in. That's not happening. You're not going to have that. You're faced with a really difficult financial position. You're faced with increasing demand, and you've got a workforce that is possibly in places looking at the world in a different way, but also in a very genuine sense, just feeling enormously under pressure.
There's lots of research into this, and there's lots of practice as well. So all of the work that Michael West, Beverly Elmore Metcalf and others have shown is that if you can create clarity on what you want to achieve, and if you look at what NHS England, Jim and Co are trying to do, say, look, let's reset in the next 3 years and let's transform over the next 7. If you can create clarity around that, if you can get people working in real teams where they know what their contribution to that is and where they support each other to overcome problems, and you support that with compassionate leadership, things get better.
How do you do that? Because there you are the leader of the health economy, if I can just put it like that. You don't really employ a lot of people. So how do you influence trusts and their boards? Because patently, and I'm not saying anything about your hospitals in your patch, but patently the NHS is a pretty poor employer, broadly speaking. How do you influence a board in a big hospital?
It starts with there's culture and infrastructure. That's what I always come back to. So what kind of culture do you want to foster, and who's leading these organisations? So I sit on the panels for recruiting the chairs and chief executives of our institutions. And we've got a set of behaviours that we've codified that we all sign up to in our system about how we want to work together and in our organisations to make sure that we are delivering the best that we can together. So through the infrastructure, through the recruitment processes, you can do that. And then the culture of mutual accountability and those behaviours that were then embedded in as much as possible, the selection, induction, appraisal of staff and leaders is the way to do it. And you do all of your work together and you see yourselves in a system. So it's really great, isn't it, that there's a legal duty to collaborate amongst trusts in the system. But the real benefit comes when there's a willingness and a desire to collaborate, because those are the kind of people that you've recruited. So it would seem to me it would be anathema for anyone in our system, the councils, the trust chief execs, the third sector, to not feel that they're part of something, because that's what we've created over the last 9 years. They feel like it's their system because it is. If we come back to the money all the time, I think we look at history with a bit of rose-tinted spectacles sometimes, because I was there. I spent 17 years in the department in Whitehall and 18 years in the service as a chief executive. The early 2000s were really difficult and really contentious, and some really contentious stuff happened. So let's remember the RCN took the government's judicial review over independent sector treatment centres. Consultants were going to go on strike over some of the changes before the consultant contract was involved. Polls at the time said managers were against the reforms. So this idea that it was really great and everybody got on with it and it made a difference, it's not true. It was really difficult. It required a lot of leadership from a lot of good people in the service.
That's all true, but it is also true that the service delivered over that period of time, and it delivered with significant additional funding beyond anything the NHS had seen, and it had a route round capital investment as well. Again, it didn't solve all the problems, but there's no doubt that by the time of the crash, sort of 8, 9, the service was in a much more robust position, and levels of patient satisfaction were higher, and people were being seen, not dying, before they had operations. So I'm not trying to be a great defender of New Labour, but that's the reality. Contrast that with now. The good intentions are there, and everybody agrees Michael West and his approach. We all know that changing culture within organisations takes stable leadership and a lot of time. The depressing thing is that you guys are going into this, it seems to me, partly with your hands tied behind your back, not least because there isn't much funding. There's massive reorganisation, things are being moved around, and you've got a lot of staff who are in a very unhappy position.
What I would say is that, it's painful to see the attrition that we've seen against the standards. Having been part of the leadership with thousands of others that delivered 18 weeks when everyone thought it was impossible, that improved standards, improved public satisfaction, staff satisfaction, performance. Over the last decade, it's been painful to see the changes. But partly that's what drives people like me to try and make it better again.
Let's just look at your particular area. Something that struck me is that the difference in life expectancy between the most and least deprived areas in West Yorkshire. For men, the gap is nearly 10 years, and for women, it's almost 12.
Yeah.
I mean, that in 2025 is just totally unacceptable. And I'm sure you agree. And the whole tone of your literature is that you do agree. My question is, where on earth do you start? And what levers have you got to change any of this?
I mean, this is why integrated care systems and the joint work with local government, the third sector and our communities, and a true partnership is essential, because those inequities are driven by largely deprivation, which then drives multimorbidity. And it's also, there are factors to do with ethnicity, factors to do with learning disability, and factors to do with mental illness. So what we've got to look at is what's the contribution on the economy, housing, education, and then what are we doing as a health service? And we think about those two things together. So where we start, we've got a housing and health programme. We've got work with the Mayor now on employment, but we also recognise our 7 billion quid is an economic investment and 100,000 jobs. And good jobs mean good health, so driving that, and then looking at things like the Fair Work Charter and so on with the Mayor. So those wider determinants are part of the solution, and then the contribution of the NHS to addressing those inequities comes when you start to look at factors like what is the experience of people trying to access services from those different communities. And if you look at deprivation, for example, people in the highest levels of deprivation massively overrepresented in the urgent emergency care system, 40 access points per 1,000 compared to 25, the lowest decile of deprivation. So a massive difference. So poor people are accessing the urgent care system. If you look at the position for day cases for those two populations, it's the other way around. You've got much more access to day cases from affluent people than you have from poor people. So poor people just getting sick in communities and ended up having a cardiovascular episode. So what you need to do is to look at what are the meaningful and impactful interventions that can help address that. And a lot of the time that's got to do with case finding in general practice for people who might have cardiovascular disease in communities. And that requires the third sector and GPs and others to work in those communities to reach those people, because they know where they are and they know where they live, to do assessments and then pick up the issues that they've got around diabetes or heart failure. And that's what we've been doing. Because we've got a very strong approach based on subsidiarity, we put as much as the money as possible. All of my money goes straight to the places. I don't keep any. And the places have an infrastructure which allow those very close conversations and design of services to happen in communities, which then allows the work to happen. So our cardiovascular disease improvements in West Yorkshire have been significant. And take account of deprivation, our performance is about fourth best in the country. But there's a lot to do with the population because it's so far behind. And I think having some of those levers, because we're saying it's a true partnership at all levels, means that we can coordinate the work at those levels to do those interventions. And because as an ICS and ICB we facilitate the sharing of good practice, then we can try and spread it across the whole of West Yorkshire. So, for example, I just got this mug out of the cupboard just by accident. It's Bradford Healthy Heart. Is now a West Yorkshire thing.
I'm really interested in this because unless we can stop people getting sick in the first place, we're just going to drown, I think. I see this as our last best chance to really stop people getting sick in the first place and really make a difference. But I just don't know if you've got the levers to do that.
I've got a lot of hope for the strategic authorities in local government. So we're co-terminus with our combined authority. The relationship with the mayor and all of the local authorities is really strong. What we're doing in West Yorkshire with all of the resources in the public sector to drive improvements in people's health, how does that link to the industrial strategy? And how do we make sure that we are looking at all those things together? And they've accepted, the thinking in West Yorkshire is, look, this 7 billion quid from the health sector is 100,000 jobs. It can be greater because we are a hotbed of innovation and tech. And we can become a global power in those things if we want to be, but we have to do it together. Then when you look at what we're doing in our neighbourhood health teams, because we've been at this for decades now, we can incentivise and pay for and support meaningful interventions, and we can look at the data for where those need to be considered. We've got a framework that says, okay, on primary, secondary, tertiary prevention, for populations that are furthest from good outcomes, what are you going to do? What are the things that are really going to make a difference to those populations from a health service perspective? So case finding people with cardiovascular disease, making sure that you are supporting them to live better and have the right drug regimen, etc., through to how do we think more about the way that services are designed in primary care to get over the inverse care law, because it still persists. Now, a design of general practice and primary care services focuses too much on activity and not on meaningful activity, which will drive improvements for populations. And us having the responsibility for commissioning primary care services, us having the responsibility for ensuring that neighbourhood services working with the third sector, the NHS and councils are designed around those populations, gives us the levers to make meaningful change happen. The big issue in an area of constrained finances, as Neil has described, is can you invest in that, or will all of the money be gobbled up from demand into hospitals? And that's the kind of path that we're trying to work our way through at the moment, and probably one of the biggest challenges.
You've said that you've been at some of this for a long period of time, and yet we still have the huge gap that Roy was referring to earlier. Is it also a question of targeting? Because there tends to be this view maybe reflected a little bit on what Roy was saying earlier. How do we stop people getting ill? The reality is, of course, if you look at a group of 40-year-olds or 50-year-olds, the heart disease is already there. It's already beating. So the idea you can flick your fingers and stop people getting ill is fantasy land. I guess the question is, and you did touch on this, it's not all about primary prevention. There's definitely work to be done there, but there's also, are people getting access to the drugs they need in order to keep them alive? Are there interventions that you can do that way? And how do you reach into people who aren't naturally engaging with the system, I guess? And that seems to me a really big challenge. So my question is, can you do that stuff, accepting you're not going to create a perfect world within 5 or 10 years, but over 5 or 10 years, can you dent that 10-year gap with the constrained resources that you've got?
Yes, we can. And I think the first point is to recognise what you've just described, Neil. There's a tide of stuff that's coming, whatever we do, because it's built in. And what we've seen is the prediction of the biggest areas of growth in that are on mental health and diabetes. So significantly bigger change in those things than some of the other long-term conditions, and that will be disproportionately in those poorer communities. We also know that people with learning disability die 20 to 25 years sooner, and people with serious mental illness die sooner, mostly driven by suicide by men in middle age. So if we think about those populations and we think about those conditions, we have to target, we have to incentivise, and we have to work in that way. It's not a let's chuck everything at everyone all of the time. It's not going to work. And I think because we've got good information and intelligence, because we do have the levers of planning in the medium term, because we've got those things, we can turn the curve. The biggest risk to that is the economy.
You're absolutely right about the economy and the bond markets, really. I mean, we're borrowing money now to pay back the interest on the money we borrowed. I mean, I can't see any real big uplift in funding the public sector at all. I can only see that this is likely to get worse and get much tighter. I was really interested in what you said about mental health, because the interim plan, or whatever it's called, the latest plan that's come out of the gasworks at the Department of Health, the mental health parity funding has been left out. It's supposed to be, if there's an uplift in funding for acute services normally, just for the benefit of the listeners, then it's supposed to go up proportionally the same in mental health services. It's not even mentioned in the document.
I think the mental health investment standard is something we've stuck to significantly over the years. And there's no doubt, if you want a strategic commissioner that's looking at morbidity and multimorbidity and designing services to meet the needs of local people, mental health's got to be a big factor. So my view is that if you've got strategic commissioners who are strategic commissioning, they need to invest in mental health services, but they need to do that in an integrated way. So when people think about, neighbourhood health services, often what's in people's heads is older adults and children and the physical health elements coming together with a bit of social care. I think all of our plans are to integrate mental health services into those arrangements, as well as having a fully functioning specialist mental health system. And I do worry sometimes that people believe that serious mental illness can be avoided or resolved through primary mental health interventions, and it can't. So I think it's a strategic commissioning question, Roy, as well as us getting our heads in what does the future look like. I think we miss a lot of seeing things from a person's perspective. What do we want for people? Well, we want them to be born in a place where they have the best start in life, supported to live well, and die in the place they're choosing. They look after themselves most of the time. If they've got a long-term condition, then they're in a team with the GP, the council, the third sector and others, and it looks after their needs and based on their lifestyle. If they access a hospital, whether it's for mental or physical purposes, it's the local one, which is networked with others to be viable and sustainable. But sometimes they're going to have to go into, a specialist unit, which might be farther away, but the quality of care is going to save your life more often and give you better outcomes. And in doing all of that, you as a person will be involved in the design and the delivery and assessment of those services. That's kind of where we want to get to. And I think that's something that people would want to fight for, and for that to be really good. What we're at the moment is a period where we do have to recover services and then we do have to transform services. So this is a medium to long-term game, unfortunately. What I would like to see is us pegging each year, how are we stepping towards that, as well as doing the waiting list recovery, the ambulance response times, etc., which are all linked to those things anyway.
We're just about to run out of time, I think. But let me just ask you how far you feel that advances in AI, advances in medical knowledge, genomics and approaches and so forth, are we at a pivotal moment where we're trying to fight the last war, not the next one, because we're not really sure just how much impact this will have, and that inevitably staff, for a good reason, are defensive or feel that if things are going to change, the nature of professional interaction may change and so forth. We didn't really prepare very well for the first digital revolution. Arguably, we've worked our way through it a bit, but the second one could be even greater, couldn't it?
Yeah, good. And I believe very strongly that we should be harnessing as much as possible around automation, artificial intelligence and digitisation. Some organisations are a million miles from that because the infrastructure is so poor. Some aren't. What we try to do here in West Yorkshire is, we've recruited a CDIO who used to run services in South Asia and East Africa as part of a global organisation. He's really good. One of the things that he's introduced is an AI academy. So he's saying, look, there's loads of stuff around which is nonsense, and there's loads of stuff that has potential. How do you tell the difference? Let's harness the things that have potential, but let's give people the skill and the will and the confidence to engage in this. So we've got an AI academy. In doing that, what I would hope is that we always see the point that this is a people business. And what the AI is doing is allowing people to have better interactions with people to deliver better outcomes for the population.
That's really interesting, Rob. Afraid Neil's right. We're up against the buffers of time. It's been so interesting to talk to you. So thank you from us both, and we wish you well in the future, and we'll be looking to West Yorkshire to see how you're leading the way. Rob Webster, thank you very much.
Thanks, Neil.
Well, Roy, I'm still left, as I'm afraid I was at the beginning. I'm not a cynic, and I hope I'm not a skeptic, but I think the task that these people are faced with and what they've been given to try and deliver this, they don't match the expectations that everybody has of the health service.
I thought he was really good, really articulate. He was clear in what he wanted to do. He had a proper focus. My worry for him is he'll run out of time. He'll run out of people, he'll run out of money, and he'll run out of political rope, because I don't know how long this government's got. I don't know what the world events are going to buffet us with, which will impact us on the funding and the money thing. And I mean, I just hope he can hang on to that vision, and I just hope that he can deliver it. I mean, let's face it, he's one of our most experienced health leaders. I just hope he's going to have the time and space to deliver it. I really do. Because like you, I am not optimistic about the future for any of the NHS, really, and given this colossal and unplanned change and the money problems and the chaos that's going on at the centre. This is not good. If he can make West Yorkshire a little island, then I think he stands half a chance.
I agree, and certainly was impressed by him. I think the other issue is, will the reorganisation, which is, as we've endlessly talked about, going to cause an awful lot of pain, disruption and distraction, will it result in something that is simpler and easier for those middle management organisations, if I can put it that way, to actually deliver something on the ground? And I do think I've always been somebody who was a bit sceptical about some of the ambitions about public health, solving world poverty tomorrow afternoon at 3:00, that you have to be really realistic. But there are interventions around which could tackle that 10-year gap, but it would take time to do it. And it would take a lot more than the health service to do it. But there are things the health service itself can do that it hasn't been doing. And I think tackling that and waking up to that, and we've known many of those things for many years, is going to be one of the key things that will face organisations going forward if we are going to see the health service start to deliver in a way that it hasn't really been doing for at least 15 years.
Very interesting point you make there. I do remember there was a thing called every contact counts. Every conversation that every nurse has with everybody in a cubicle somewhere or other. I thought that was a great policy at the time. I don't know what happened to it. I think everybody was too busy. If we really are going to make inroads into that, we need to think about making every contact count. Interesting. Thank you, Neil.
Thank you, Roy. We will be back again soon. Thank you all for listening, if you have been.
Bye-bye now.
Bye.